Thank you, Professor Silverman. What policy measures have been taken to achieve health equity during COVID, especially when this was a challenge during the H1N1 flu epidemic? And that's for you, Professor Silverman. You're on mute. Yeah.
So there we go. It's that tricky click there. I think again where we need to outreaches, it needs to be where the need is greatest. I think the distribution networks, I mean, there are national distribution networks, although if we look back to to the H1N1, if we look back even further to the swine flu epidemic, I mean, it took months and months to reach a percentage of the population. So we have to, again, communicate that 300 million doses of this vaccine, of whatever vaccine is first out of the gates, is not going to be available in the first weeks. And so we need to have a national discussion about prioritization and ensuring that it is a stratified approach that targets those who are most at risk and those who we need in order to sustain our healthcare systems and our public health systems in order to respond, continue to respond to the outbreak.
Thank you so much. Thank you for thank you for the excellent discussion. Now I'd like to take some questions. I know we've used up most of the time, and I think some of the questions have been answered, but I might just end with one question, broad question here that we've gotten. As legal experts, please offer practical anti-racism advice as to how to effectively address racism and bias in frontline healthcare settings, for example, emergency departments, hospital wards.
Yeah, I can start. So one of the things that we see with our healthcare system is that if you are a Black American, if you're a Latino American, if you're a Native American, you're much less likely to get care from somebody that's within your own racial or ethnic group. And so one of the things that we could focus on is ensuring that we have more healthcare workers and physicians in those from those ethnic groups being represented. And so in terms of making sure that we have a focus on that kind of education, and making sure that the profession is friendly to all groups that, regardless of your racial or ethnic heritage. And so one of the things that we've seen in studies, empirical studies, is that the treatment that people get when they have a healthcare professional that matches their ethnic or racial origin, it's a lot more positive. And so that itself, without any kind of anti-bias and without any kind of implicit bias training, that would help just in terms of the workforce. Dana Bowen Matthew has written a great book where she focuses on the fact that medical education itself should be in unjust medicine. She talks about how medical education should focus on implicit bias and biases that people have with regards to the fact that there are still medical students, that there was a study at a UVA a couple of years ago that believed that Black people don't feel pain the same amount as other races. And so you can see that when someone is coming in complaining, there are lots of concerns that people are being turned away. And so the training that people are getting from medical school can be another way. And I'll leave it to Professor Yerby and Professor Silverman if they have any other thoughts.
For me, another practical way to address discrimination in the healthcare system is to actually apply the laws equally across the board. So right now, we have Title VI, which prohibits discrimination. We have 1557 that has been revised, but it's supposed to apply to not only hospitals, nursing homes, healthcare workers, physicians, healthcare providers, as well as health insurance. But you rarely see cases being brought against healthcare providers, insurers, anyone really in terms of racial discrimination. I think when you look at states, Michigan's governor actually just, I think, did an executive order or passed, the legislature passed a bill mandating that healthcare professionals every year would have to do some implicit bias training, which is a great first step. But for me, and Professor Jonathan Kahn has written about this, it's not just about implicit bias, right? It is about explicit bias from healthcare providers to patients, but also patients to healthcare providers and within the healthcare system. And so we need to ensure that if we want to make a change within the healthcare system, that we have to enforce the laws that we have on the books that say do not discriminate against women, racial minorities, the disabled, LGBTQ. And one last thing I will say, it's also important that the healthcare providers working within the system are treated fairly. So that means paid fairly, respected as well. And I'll stop there.
Toward those ends, I think also that we need to continue to build the connections between our hospitals and our health systems and the communities in which they're located and which they serve. And this also means, this can go into everything from having community-based partnerships where it is not just interdisciplinary but transdisciplinary, recognizing the insights and the values that the community members themselves bring to the table, that it's not just being brought from the hospitals or from the ivory tower into those communities. I think is a significant aspect in this response. I also think, we'll put in a plug. I'm a huge fan of medical legal partnerships as well, as far as and civil legal aid integrated into health delivery systems as a way to again try to continue to address the policies that are either being inappropriately applied, or benefits that are being or that are available that aren't being accessed, or that are being inappropriately denied, as a way to also supplement services to our most at-risk populations.
All right,
Great,
thank you.
So
yeah, I'm going to pass it back to you, Lynette, to wrap up.
Sure. Thank you all so much. This has been such a great discussion. I want to end, we've sort of discussed a lot of very troubling things, a lot of challenges that we've had to encounter, and some of the work that you have on combating and addressing some of the issues. I want to end on, if you could, just to describe some initiatives or some strategic approaches towards some of the issues that we've talked about, in terms of where do you derive your hope and your inspiration, and places in which you see this hope springing from, if you will.
I could start. I would say that at this moment where we have COVID-19, where we have the protests around police killings, where we have people who are unemployed, that I've seen a shift in the discussion in public health around racism as a public health crisis. Before COVID-19 started and some of the protests, there was only one state that had actually passed anything regarding racism as a public health crisis, and that was Wisconsin. And there were a couple of other counties, one in Pittsburgh, that had issued any discussion about racism as a public health crisis. And now almost every day you see governors, cities, counties, school districts issuing these resolutions, which is great. My hope, though, is that they become more meaningful, that they really begin to address the structural inequalities that I think that definitely the Black Lives Movement has been focused on, the Occupy movement focused on, that the Poor People's Campaign back during Martin Luther King's era, and the continuing one with Reverend Barber are focusing on. That if we want to address the public health crisis, right, racism is a part of it, but it is also about poverty. It is about sexism. It is about ableism. And so we need to ensure that workers have health insurance, have paid sick leave, that they have the support that they can to be able to do the things that they need to, that we have fresh water, that children have a great education and ability. That is the public health crisis, that we have a system that is set up so there's always people at the bottom. And to me, that is the public health crisis. And so I'm heartened by the fact that lots of places are passing legislation to say this is a public health crisis, but make sure that you're addressing structural inequality and actually providing money and support to be able to address it.
Thank you, Professor Mahapatra and Professor Silverman. I don't know if you have any parting thoughts.
Well, I agree with everything that Professor Yerby said, and I'll just, in terms of like leaving with a little hope, the lack of a kind of coherent policy, a lack of supports on a federal level, on a state level, I feel like that has pointed out to the lay individual the need for the role that government plays and the ability that the government has to impact people's lives. And so I am hopeful that there, instead of kind of leaving people on their own, that a government that people want a government that is supportive of their day-to-day policies and how they live, and they're protecting their health. And so I'm hopeful for a more robust system of like statutory support, whether it is for healthcare, whether it is for, income, wage as livable wage, but I'm hopeful for a stronger role of government, and that we see what happens when we don't have that.
And to build on that thought, for me, what this I think has also shown, to borrow the Tip O'Neill phrase of all politics is local. I mean, we know all public health is local, and I think this public health, healthcare, there has always been a call to advocacy and a responsibility, an ethical responsibility, especially within public health, for advocacy. And I think engagement with local policymakers is a critical component of the future of public health, and a responsibility that we have to continue to educate and engage, especially at the local level, with our policymakers, because again, without those voices at the table, we can see what the impact can be upon the lack of those voices at the table can have as far as decisions that are being made that affect all of us.
Perfect way to end. Many thanks again to our panelists today for sharing their scholarship in the field of health justice and equity. We're grateful to be able to engage in this forum with you all. This concludes our series for the COVID-related topics. We hope that you've enjoyed the series as much as we've enjoyed putting it all together. And it has been an absolute privilege to be able to engage in this forum for continued collegial engagement and scholarship. Please look for the recording in the Affinity Group Dropbox. If you're not a part of ASBH, we'll be posting it elsewhere. Details to follow, possibly on mediums such as YouTube. In the next few weeks, we'll be developing another set of COVID-19 related topics on the intersectionality of bioethics, law, and policy. For that and further details on that, please follow us on Twitter. And we hope that you continue to be well and safe. And we wouldn't be here without acknowledging our workers on the front lines, both in public health and also the essential workers that we owe much of our days to. So thank you very much, everyone. And we hope that we see you next time for the next set of topics that we cover in our series. Thank you.
Thank you.